Welcome everybody to this edition of the Inter-CFAR HIV-TB Working Group webinar. I'm excited today to have Dr. Emily Kendall presenting. Emily is an assistant professor of medicine in the Infectious Disease Division at Johns Hopkins University School of Medicine. And her work focuses on infectious disease dynamics, antibiotic resistance, particularly in tuberculosis, and has led multiple high-impact publications modeling different treatment and diagnostic strategies for tuberculosis in the developing world. And it's a pleasure to have you here today, Emily. We're just waiting for a few more people to join. But as a reminder, the format of this is that the speaker will present for perhaps 30 to 35 minutes or so. And what I would like people to do is hold their questions until the end. They can certainly send their questions through via the chat or just note to me that, or to everyone, that they have a question in the chat. And then once Emily's done presenting, I'll just go in that order and call on you to ask your questions directly to Emily. So let's see. Many people. We have 26 people here. Why don't we just give it a couple more minutes for people to join? Typically, there's a good addition of people that show up in the next couple minutes, and then we can go ahead and start. And I see, Emily, you've taken control of the screen, which is great, and you can advance. And everybody sees the chat window. Yes. Just a reminder to everyone, I have been getting emails with people asking to be on the email list. This is a group, there's no application, you don't need to have a sign-in, a username, password. Just ask me. Anyone interested in joining can join. I'll put you on the list and provide updates as to when the next webinar will be scheduled and instructions to join. So with that, again, I'd like to introduce Emily Kendall, MD, PhD, assistant professor in the Department of Medicine and Infectious Disease at Johns Hopkins School of Medicine. Emily did her MD work at University of Vanderbilt, then her residency at Mass General, and then subsequent training at Johns Hopkins doing infectious disease modeling. Delighted to have you here today, Emily. She's going to be talking about her talk, Activity Under the Radar, Community-Wide Xpert Ultra Testing and the Dynamics of Undiagnosed TB. Emily, why don't you go ahead and take it away?
All right, great. Thanks, Greg. Thanks, everybody, for the chance to present. So yeah, I want to talk today about sort of the dynamics of what's happening before TB reaches the point of clinical detection, thinking partly about what we know and sort of can understand in general, and then describing in particular a couple of studies in Uganda, one that we're wrapping up and another one that's just getting started, that are trying to get at some aspects of this question. And I think this is a group that knows TB well, but I would challenge sort of us that the TB that we have the most data on and that we know well is TB that is in people who are symptomatic or high risk enough to get tested, that's diagnosable with available tools, and it may not be representative of all the TB that's out there and potentially important from an epidemiologic standpoint in terms of contributing to transmission at any given moment. And we also, because once we diagnose TB gets treated, we don't often get to observe the dynamics of what's happening over the course of TB disease. And there's some data, like cross-sectional data, either historical data pre-antibiotics or cross-sectional data that can allow us to get some sense of these dynamics. And one thing that has become apparent from prevalence surveys over the last decade or two is that there's a lot of prevalent TB out there relative to the amount of TB that gets diagnosed. This figure on the left is in the WHO's Global TB Report every year, and it shows results of prevalent surveys compared to the number of bacteriologically positive TB notifications per year in the same setting. And what this shows is that across 20 or so countries that have done prevalent surveys in the last 15 years, nearly everywhere, for every TB case that gets bacteriologically diagnosed, there's at least one person year and typically multiple person years of prevalent TB in the population. And that doesn't mean that every person is spending multiple years with TB before they get diagnosed, because some of those cases resolve spontaneously, some lead to death before diagnosis, some get clinically diagnosed. But it does show that there's a lot of prevalent TB person time out there relative to the number of diagnoses. You know, a lot of people spending a lot of time with bacteriologically detectable TB. A systematic review of these prevalent surveys also showed that about half of that prevalent TB is asymptomatic or subclinical as judged by a standard symptom survey that looks at something that asks typically whether you've had 2 weeks of cough or sometimes cough and or constitutional symptoms. And I think understanding this population and not just the size of the population, but some of the dynamics of who's contributing to it and when is important for, I think, understanding its epidemiological role and understanding how to go about intervening on it if that's something that is worth doing. From a terminology standpoint, I mean, this often gets referred, the asymptomatic or less symptomatic portion gets referred to as subclinical, asymptomatic, and maybe more just minimally symptomatic, that people have mild symptoms they aren't recognizing. I think it sometimes gets called early, but I would argue in some cases people have been in this state for potentially a long time. I've started to steal from Emily Wong in this editorial here. I've screenshotted the term subtle that I think describes a lot of these cases. But the question that I think we need a better understanding of is what role does this prevalent TB, and particularly the subclinical forms, play in TB epidemics? And I think that requires understanding, and not just the burden, but what happens to it over time. And so we can ask, what do we know about the differences between the TB that we that's easily observed, that we diagnose through sort of routine clinical care, and the overall burden of prevalent TB that's out there? And an obvious difference is the stage of disease. You know, we're talking about people who haven't reached the point of recognizable symptoms that get diagnosed. Talking about people who are in these earlier stages of subclinical TB. But the fact that, you know, the arrows here in this figure are illustrating that it's not just a steady progression forward through this trajectory of latent, incipient, subclinical, clinical TB, but that there can be movement back and forth, that TB can improve or resolve even without treatment, and that different people are likely to move through this path at different speeds and possibly with different overall courses. And so another difference between sort of diagnosed and prevalent TB that becomes apparent from looking at notification data and results of prevalent surveys is that the cases we diagnose are people who have a different pace of progression than the prevalent cases that aren't getting detected. And this is sort of most apparent for HIV, where HIV, because it causes people to advance to clinical illness and diagnosis or death more quickly, tends to be more represented among the notified cases than it is among prevalent TB. And in prevalent surveys in Uganda, you see that the prevalence of HIV among prevalent but bacteriologically detectable cases is about half as great as the burden of HIV among notified TB disease. And this figure on the left is sort of illustrating what's happening here. You know, if you imagine that there are two forms of TB, an orange form that progresses quickly and a blue form that progresses slowly to the point of clinical diagnosis, or in some cases not at all, may resolve without ever developing symptoms or getting diagnosed. Then you see here that half of the incident cases originating from the bottom edge are the orange rapidly progressive form, and half are the blue form. But the majority of the cases that are getting notified, by reaching the top here are the orange form, whereas any cross-sectional prevalence survey, any of these sort of vertical dashed lines, the majority of the cases that get detected are the blue form. And which just points to the fact that there are differences that between notified and prevalent cases that can potentially give us some insight into what these dynamics are over time and the degree to which they are heterogeneous across the population. Another difference that's apparent between prevalent and notified cases from these prevalent survey data compared to notification data are demographic differences. These are data from the recent South African and Ugandan prevalent surveys that are really examples of patterns that are seen elsewhere also. Now, instead of the single national level prevalence to notification ratio, I've included across the bottom the prevalence to notification ratio within individual demographic groups. And you see in both South Africa and Uganda that there's a much higher P to N ratio among the youngest and oldest adults than there is than among middle-aged adults. And in Uganda, there's also a big difference apparent between men and women in terms of men having much more prevalent disease relative to the number of notifications. I think we don't know what the reason for that is. It's probably a mix of factors. Are there differences between different age and sex groups in terms of how quickly TB progresses? Is it a difference in symptom recognition or whether symptoms can be distinguished from other symptoms people have due to other chronic illness or smoking-related illness or something? Is it a difference in healthcare access or willingness to seek care for the same level of symptoms? And it's probably a combination of probably different factors in different groups. But the fact that you have certain demographic groups that have this high burden of prevalent disease suggests that the people we're diagnosing with TB, that there may be groups out there that are large contributors to prevalent TB person time and thus potentially to transmission out of proportion to their sort of representation among the TB patients that are getting clinical attention. And I think the fact that there is this large burden of prevalent TB out there and that it's potentially not in the same groups that we care about from the standpoint of high clinical risk and need to diagnose to prevent poor clinical outcomes, this prevalent TB could potentially be a key to controlling epidemics because it could be playing a large role in TB transmission. This figure from a sort of recent perspective written with Surya Shrestha and David Dowdy illustrates the principle here. If you imagine that there are sort of three broad categories of the course of TB disease, the rapidly progressive cases who are at highest risk for morbidity, mortality that need to be have TB prevented or diagnosed early in order to prevent poor clinical outcomes, may spend a very short time with potentially infectious TB, whereas there are others who may have a more stuttering course with a lot of time with mild or no symptoms and a long time before they actually get diagnosed, or there may be people who spontaneously resolve before they ever develop clinical or before they ever develop clinical disease. And those two groups potentially spend a lot more time with prevalent and potentially infectious TB. And if you think about what's happening with transmission, now plotting cumulative transmission so that the height is how much transmission someone has generated and the slope of the curve at any given moment is how infectious they are. This person with a rapidly progressive disease is likely to contribute relatively little to transmission relative to these other groups, even if you assume that the symptomatic periods are more infectious, sort of steeper curves than the asymptomatic periods. Still, the differences in person time are significant enough, and if it's possible to be at least moderately infectious when you don't have symptoms, and things like smear positivity among asymptomatic cases suggest that it is, then they could potentially be big contributors to transmission. And if that's the case, then diagnosing these cases earlier, particularly with some sort of symptom agnostic approach to case finding, could potentially avert a lot of transmission. But I think there are things about the dynamics of early TB that we don't know that we really need to figure out in order to know how much is this really the case? How much of an impact can we really have through seeking out these subclinical cases? Part of that is how much turnover is there between subclinical and resolved TB. We know that TB can resolve without intervention, but how much does that happen? If it's one person who's spending multiple years with subclinical TB, then obviously it's worth finding that person early. If this is a whole lot of people who are each little blips that are briefly developing TB and then resolving, then focusing on case detection as opposed to prevention or something else may be may make less sense. Another question is how infectious, how much steeper is this curve of cumulative transmission during symptomatic periods versus asymptomatic, and how much does it increase over time as you approach the point of clinical detection? And there's some limited data on this, but I think not nearly enough to really prioritize this population correctly. And then from a resource standpoint, I think we also need to figure out how hard is it to find, like how can we find efficient ways to find these cases, or particularly to find the right or most important ones who are either likely to go on to eventually have clinically significant disease, or the ones who are now or in the future going to be major contributors to transmission. I want to share a couple of studies that get at these questions really in just small ways. But are an attempt to start answering, or to contribute another small bit to our understanding of who this population is and what their epidemiological role is. I want to start by describing the STOMP TB study, which is something I've been working on with David Dowdy as the PI. I've been involved since, I guess, the end of my fellowship training, and it's nearing completion now. But this study is designed to take a detailed snapshot, sort of more than just prevalence survey and notification data, but in a small community, to describe in a more comprehensively, at higher resolution, what prevalent and notified cases look like. The study design is that we identified a sort of geographically defined area within Kampala, with a population of about 50,000 people, about 34,000 adults, and over a 4-year period have been sort of passively enrolling everyone from the study area who gets diagnosed with TB through routine care, doing this through constant monitoring of routine practice at all of the local health facilities that diagnose and treat TB. And then, in addition to that, in 2 waves, once in 2019 and then again now in an effort that's happening this year, going through the community and attempting to test every adult with a sputum Xpert Ultra test. Ultra was rolled out right at the start of our first active case finding wave in 2019. So identifying routinely notified cases, trying to identify every prevalent case during these 2 shorter windows of time, using door-to-door case findings and like the sort of neighborhood-wide case finding events, contact tracing after we do find a case, trying to find everyone who has TB. And then next steps will include whole genome sequencing and combining that with epi data to map transmission between these cases. And the ultimate goal of this study is to design efficient and effective approaches to TB case finding or prevention. Here's a little bit more about our approach. Here's a map of our study area. During these 2 community campaigns, we visited every home in the area. We also held venue-based events, typically a weekend day where we'd set up a tent and play music and invite everyone who lived nearby to come and get tested. And as we move through the community, we'll also recruit residents anywhere we encounter them, on the sidewalk, at their workplace, corner shop, that sort of thing. Typically, we have about 10 field staff out doing case finding, partnering with community health workers. We tested every resident age 15 years or older, and the specimen we're testing is expectorated sputum, with basically telling everyone to give us something. Take your time, take deep breaths, jump up and down, but then just give us whatever you can. And we get a lot of low volume and poor quality sputum, although we've actually seen that the low quality sputum gives nearly as high a positivity rate as the higher volume mucoid samples. And then the testing is Xpert Ultra, which we've been performing at a central laboratory. And for purposes of the results that I'm going to show today, we've defined a case as any positive Ultra result, although I'll say more about the trace results toward the end. And the way we characterize these prevalent and diagnosed cases, we collect additional sputum for culture, smear and culture. We've done an interview that includes symptoms, care-seeking history, TB risk factors. We do HIV testing, measure C-reactive protein, do a contact investigation. And we end up with these three groups that I'm going to show you the comparisons between. The community-based cases, the people we found through these community case-finding activities. I'll show results today just from the first of these two community-wide screening campaigns. We include randomly selected participants in this community screening who tested negative as TB negative controls. And then over a longer period, we've been continuously enrolling the health facility TB cases who come from the same geographic area. And I'll show a few results just in terms of the yield and implementation of this case-finding approach. I mentioned there were about 34,000 adults in the study area. We ended up screening about 12,000 of them. We did find that it was harder to track everyone down, find people at home than we hoped. And so it's just about 40% or 36% of the estimated adult population that we were able to contact and that consented to screening. Of those, we got valid Ultra results from nearly everyone. Like I said, not always great quality sputum, but we think we have some indication that it was still enough for the molecular test to pick up TB when it was present. And of those 12,000 tested, we ended up with 113 positive Xpert Ultra results, just under 1%. And in addition, we diagnosed 4 community cases, 2 through case finding, and 2, interestingly, of the 139 randomly selected ultra negative controls, 2 had positive sputum cultures and got included in the community case population. And over the same period of time, or prior to and during that first round through the community, there were 95 people diagnosed with TB at the local health facilities who we also enrolled. And like I said, we found about 1% of Ultra results in general were positive. And interestingly, we found that this venue-based approach, where we would set up a tent and ask people to come get screened, was well received and successful at finding cases. The proportion of tests that were positive at these events was almost 3%. The demographics were different. The venue-based participants were majority male as opposed to the at-home participants who were majority female. But that didn't explain the difference in prevalence even after age and sex adjustment. It was still 3%. So it was both high-risk men and high-risk women who were coming out to these venue-based events. I think it's not clear why. Is it that the people who are like not home during the week but willing to come to these just sort of more mobile and they have more contacts and potential TB exposure in general? Do they, because they're working, have less healthcare access? Or were people self-selecting for symptoms or risk factors in terms of who came out for testing? We have some indication that all of these are contributing, but I think we don't know for sure. Another pattern we saw is that hotspots of prevalent TB were identifiable from notification data in the preceding year at these health facilities. This shows the zones that had the highest notification rates based on local notification data. And during the community-based case finding phase, we found that those zones were also some of the highest in terms of TB notification rate. So that, if we took the 5 highest risk zones here, they accounted for 22% of the population. They were 62% of the health facility TB cases in the year before this community case finding. And we found that those zones also accounted for 42% of community cases, suggesting that notification data, can be used to identify hotspots, and that it's not all a matter of people in these. It's not all a matter of healthcare access, but that the notification data really is representative of where TB is. And then I want to show results related to the characteristics of these TB cases, comparing the cases found through this door-to-door screening pictured on top to the cases getting diagnosed through routine care at the local public health facility and the other 3 smaller health facilities that we were enrolling from, shown at the bottom. So, as has been described many places, the cases were majority male. As I had mentioned before, in general, the people that we were able to find and enroll were majority female. And so we ended up with more female predominance among controls. The HIV prevalence is reflective of what I showed in the sort of introductory section, that the prevalence of HIV among the cases we found in the community was a lot lower than the prevalence among the cases getting diagnosed through routine care at health facilities. Other risk factors were similar in terms of like TB contact and smoking, which smoking is somewhat reflective of just sex. But yeah, some similar rates of TB exposure, somewhat lower rates of healthcare contact among the community-based cases than those getting diagnosed at the health facilities. In terms of symptoms, we saw a prevalence of TB symptoms in general and of cough of 2 weeks or more in particular, and an intermediate prevalence among the community-based cases compared to these other two groups. We also found that the CRP prevalence was, or the CRP levels were somewhat higher among the community-based cases than controls, but were much lower than among the health facility cases, and the sensitivity of CRP was much lower for detecting these community-based cases than what an abnormal CRP was for detecting health facility cases. Most of these community-based cases were sputum, smear, negative, and culture negative, which I'll show you more about. If you look at the distribution of Xpert positivity, there were a lot of trace positive results among the community-based cases. And I'll discuss more who these people are and sort of whether they really warrant the term case. But even among those who were testing positive at levels higher than trace, there was sort of a skew toward the left, toward lower semi-quantitative Xpert results among the community-based cases compared to more sort of medium and high results among the health facility cases. I want to say a little bit more about the background on this trace result of the Ultra test. So the original Xpert MTB RIF is the nucleic acid amplification test for detecting Mycobacterium tuberculosis. It used 5 RPOB PCR probes that were used to detect both MTB and rifampin resistance. The new Ultra cartridge that was first introduced in 2017-2018 adds 2 additional probes to these insertion sequences that typically are repeated multiple times in the M. tuberculosis genome. And including probes to those regions allows for more sensitive TB detection. There are also some other improvements of the Ultra cartridge, improvements to the RPOB probe, some increased sample volume, things like that, to try to increase both sensitivity for both TB and rifampin resistance. But this trace result in particular is the result that the machine gives when the insertion sequences are detected, but RPOB is not. And in sort of preclinical analysis, this result is typically seen at around 10 CFUs per milliliter. And inclusion of trace positive results, inclusion of these sort of IS-6110, IS-1081 results only, along with those that detect both probes, increases the sensitivity of the assay and also reduces specificity relative when you're using, at least compared to culture as a reference standard. These shown here on the bottom right are some data from a clinical diagnostic accuracy study among adults, symptomatic adults being evaluated for pulmonary TB. And you see that the Xpert Ultra on the bottom compared to Xpert at the top increases sensitivity, particularly among smear negative cases, but reduced specificity in this study from 98% to 96%. And trace accounts for a significant proportion both of the increase in sensitivity and the reduction in specificity. And so one question is, who are these ultra trace positive individuals? Are these just false positive results? So most of them were culture negative, or are they somehow revealing a wider spectrum of disease or telling us something about these early TB dynamics? You see here comparing, so I'm splitting out what was previously the middle column into 2 separate columns, one for those greater than trace and one for those with trace results. And you see that both are low HIV prevalence, both have higher rates than controls of a known TB contact, higher rates of smoking. lower rates of healthcare contact than the community controls. And you see that both the trace and the non-trace had higher prevalence of symptoms, TB symptoms in general and chronic cough in particular compared to the community controls, although the prevalence of symptoms is higher among the sort of definitive positives than among the trace positives. In terms of culture results, only 14% of those trace positives had a positive culture result. We were doing just a single spot sputum, often on a low quality sputum. So even among those higher than trace or among the health facility diagnosed cases, there was still a substantial proportion that were negative on a single culture, but it was a lot lower on the trace positives. Prior TB treatment, which sort of leaves the DNA of dead bacilli around in the airways for a while, is known to be one potential cause of false positive ultra results, but it explained only a small proportion of the trace ultra results in our population. Over on the right is the CRP distributions, with the community-based cases split out into more than trace above and trace below, and you see that there's neither are nearly as high as the health facility cases, and again you see this same spectrum where there's still some small difference between the trace positive cases and the controls. Sensitivity at a CRP of 10 is a lot better for the health facility cases than it is for even the sort of definitively positive community cases. I think one interesting thing to note here is that fortunately the specificity of ultra in our population, even if you assume that all of the ultra positive culture negatives were really false positive ultras, that still puts a floor of specificity at above 99% in this community-based, in a community-wide screening context. So fortunately higher than the 96% that was described in a clinical setting, although still that means that the majority of your cases that you find if you're using ultra as the primary way of doing case finding are ultra positive and culture negative, which is we really need a better way to distinguish who has true TB. So to summarize findings of STOMP, particularly so far, there's more still to do, but so far in terms of looking at the prevalent cases relative to relative to routinely diagnosed cases in the same community, and thinking about how to go about finding cases in a community setting like this. I think first of all, our study does demonstrate some operational success with community-wide sputum testing. We found that venue-based weekend events were a high-yield approach, with about 3% of ultra tests being positive. We found a lot of TB, but for example, more cases than what were diagnosed over in the local health facilities over a 1-year period, but exactly how much we're finding depends on your definitions of which of these are really a TB case. Going forward, we think that a more efficient way to do case finding is to conduct chest x-ray screening with ultra confirmation in terms of both efficiency, logistical feasibility, and accuracy. In terms of comparing health facility versus community cases, we see this spectrum of disease severity from the health facility cases to the community cases, and among the community cases between the ultra sort of higher than trace versus trace compared to controls. Spectrum in terms of symptoms, in terms of bacillary burden, in terms of host inflammatory markers. We see fairly similar risk factors in terms of things like TB exposure and smoking, but HIV is notably much lower prevalence among all of the community cases than it is among routinely diagnosed cases. Again, saying something about pace of clinical progression, I think, and the different dynamics of TB, the different path of a TB course that prevalent cases are on compared to the cases that are getting diagnosed. And I think this leaves us with the question about whether the trace positive culture negative individuals that we find through this kind of community-wide testing are part of the same spectrum of TB disease severity and pace of progression, or whether they are just false positives. And in order to really understand what to do with this data, I think there's still a lot that needs to be answered about these questions I raised earlier in terms of is finding these subtle cases in the community, including potentially the trace positives, averting future clinical disease, or are a lot of these people who would just resolve without any intervention if we hadn't gone out and actively found them? How much transmission are we able to prevent, particularly when we're finding people who currently have paucibacillary disease, but even for the ones that we found that were smear positive, for example, how much transmission are we preventing? How much transmission are they responsible for compared to the people who are coughing and symptomatic and in seeking care in clinical settings? And our approach of testing every person with an ultra test is certainly not a cost-effective or scalable approach, which leaves us with questions of, can these populations be found in a way that's cost-effective and scalable? In terms of next steps for the STOMP study and data, we are, as I said, doing a second round of community-wide testing now. We're interested in looking at the impact of our previous round of case finding on disease burden in terms of the quantitative prevalence of TB, the characteristics of the cases that we find, and also the impact on routine notifications in the health facilities over the course of the study, although that will be a little bit difficult to tease out from the impact of COVID. We're doing whole genome sequencing of all of the culture positive cases that have been diagnosed in order to sort of understand transmission patterns and look at whether some of these actively diagnosed cases can potentially be linked to transmission. And we also have started a new second sort of related study looking more closely at the trace positive. So I want to spend the last couple of minutes telling you about this study, that one of our next steps is a prospective cohort study of ultra trace positives, sort of trying to understand how many and which of them are true positives, like which of them actually have active TB at the time of their trace positive result. How should they be managed, given that this is likely paucibacillary disease, or we don't, like, what additional diagnostic evaluation or treatment should they receive? Like, what is their risk? If they don't have TB now, what is their risk going forward? How should that be managed? And then we're interested in looking at what this population might reveal about TB dynamics. And basically the hypothesis underlying this is that trace positive results, even when they're found in someone with a negative culture and only subtle possible evidence of TB, may be able to, that these individuals may be able to shed light or like offer us a window to observe aspects of early TB dynamics that we don't often get to see. That if ultra and sputum culture are designed to have roughly the same sensitivity, there's this, that people who have a trace ultra result, even if they have a negative culture, may have TB DNA, culture may be barely missing them, or they may have TB DNA hanging around but no longer any viable bacilli because they recently had TB that resolved spontaneously, or because they're one of these people whose immune system is sort of barely controlling TB and they're sort of intermittently culture positive, never really symptomatic. Maybe some of them are in sort of the earlier incipient stages of developing TB. Maybe some of them were recently exposed to TB, have it in their airways, maybe were recently infected. And we're interested in using this population as a potential window to observe developing TB. And with that goal, we have set up a prospective cohort study of ultra trace positive individuals, drawing them now from this second round of community-wide case finding that's happening as part of the STOMP study, and then planning to continue to do similar case finding in other parts of the city after we complete our pass through the STOMP study area. We're recruiting ultra trace positive individuals for a detailed baseline evaluation that's designed to detect any active TB that may be present, including additional microbiological testing, chest imaging with both X-ray and CT, and some symptom monitoring, including objective cough measurement, trying to understand who has TB now, and then for those who don't have findings of TB that warrant immediate treatment, we're going to follow them off of treatment to observe whether these individuals have an elevated risk of developing incident TB compared to age, sex, and HIV matched ultra-negative controls. We're also doing the same baseline and detailed characterization of the definitive prevalent, many of them subclinical TB cases that we find. And the goal is to understand how many of these individuals have prevalent TB. For those who don't, what is their risk of developing incident TB over 2 years of follow-up, and can that be an opportunity to observe the earliest stages of TB before it becomes either like infectious or clinically symptomatic, and then understanding the implications of our findings in terms of how to conduct case finding and how to use Ultra or other TB tests that have imperfect specificity as when we want to detect TB at a sort of large population scale. So to summarize, I think there's these differences between prevalent and notified TB that are important to understand if we want to know the role of subclinical and more slowly progressive TB from an epidemiologic standpoint. I think we want to recognize that it's not just a different stage, but it's potentially different people on an entirely different course of TB disease than the ones that quickly reach clinical attention. And these subtler forms could be epidemiologically important, but we need to know more about their future trajectory and infectiousness in order to really prioritize them properly in our sort of resource investment in TB control. Practically, I think doing impactful case finding requires us to understand this TB natural history and how it interacts with available diagnostics like Ultra. And then Ultra in particular, I think, is a useful but imperfect tool for case finding, but we're hopeful that it may also shed light on early disease dynamics. Quick thanks to David Dowdy, who's the PI of the STOP study and a mentor to me and involved in all the work I shared here, to the whole STOP TB team here at Hopkins and in Uganda, and the Turn TB study team that's helped me get this new study started over the past few months. Sergesh Swas has done a lot of this work on subclinical TB, have NIH funding for these projects, and a lot of close collaborators in Uganda and here at Johns Hopkins and the Center for TB Research. Thanks for your attention, and I would love to answer questions.
Wow, fantastic. What a fascinating study. I just have to say that was really superb and an incredible effort in identifying. It's just so interesting to see this sort of new spectrum of TB in this setting being captured, potential TB being captured and studied. Really, really fantastic. So I wanted to, I have a bunch of questions, but I wanted to go in order. Dick will start us off with the first question.
Thanks. Emily, great stuff, really nice. And I want to congratulate you, especially you and David, for maintaining the superiority of TB studies for both logos and acronyms. You've done a great job. I love your logos and acronyms.
All right, thanks.
My question is not about your studies, actually, but it's about the model and your introduction and the way people talk about TB behaving with and without HIV and the natural history. And my concern is that overlooks something that is very important at a population level, and that is that there are a lot of people who have TB infection who then acquire HIV. It's one thing to have HIV and get infected with TB, and then you fit nicely on that orange line of rapid progression. But for people who have TB infection and then acquire HIV, we know that it can take, years for them to become reactivated. And I just wonder how that fits into the modeling of what happens at a population level and how you might account for that.
Yeah, I mean, so I was laying this out more in terms of thinking about what happens once someone develops active TB, and obviously the dividing line there is not a real well-defined one. But yeah, thinking about like once someone does reach that point of developing bacteriologically detectable, sort of what we would consider the people that we're going out when we do case finding, as opposed to the people that we're targeting with prevention, preventive therapy, and otherwise. But you're right, that could be because they had HIV and then they developed TB, or it could be that of course is triggered by someone who had been already like previously TB exposed and controlling whatever infection they had, then getting HIV infected, and that can set them off on this more rapid course that doesn't just start from the point of where active TB begins. Obviously HIV is changing the sort of trajectory and time course of the development of active TB also, once the HIV infection or immune compromise is there. Yeah.
Okay. Thanks, Dick. Thanks, Emily. I had raised my hand here. I was interested in the collection of sputum on asymptomatic people and was thinking about
Hmm.
sort of you had said this is obviously not sort of a cost-effective approach, but it reminds me of the sort of efforts to pool samples and looking for acute HIV. I wonder if you guys thought of that. Pooling sputum samples from if you're going to do that many Xpert Ultras. I wonder about
Yeah,
that approach, and then because really if you're identifying people who may be trace positive, like you're saying, you're not sure what to do with them. It matters if they
right,
have symptoms, but you're not sure what to do with them. But it is a group that may need to be, it certainly needs to be followed closely. So you wonder if
right.
you could pool a certain number. You guys, I'm sure, are great at modeling that. But have you thought of that?
Um, yeah, so because we decided we wanted to look in more detail at this trace population, and they're probably right on the cusp of being detectable even with undiluted or like unpooled sputum, we are continuing to test, individual sputum samples. But I know that like Guy Marks, for example, has published a couple of pieces looking at pooling of expert specimens and has found that there's relatively little loss of sensitivity when you pool several specimens. And so, I think not focused on trace in particular, but thinking about sort of asymptomatic in a community population expert testing, that does seem to be a viable strategy. I think there's potential that will become recommended in the next few years.
Hmm.
And I think another question is, do we need to find the most paucibacillary cases, or how much of the impact of, if our goal is to reduce transmission through active case finding, how much of the same impact could you have by just detecting them like sort of people with higher bacillary burden? And like, could you, I think there's potentially a role for a lot of specimen pooling or less sensitive methods if your goal is to find just the people with a high disease burden who are potentially highly infectious now. Um,
Hmm.
but
I have
yes,
a
they're
question.
like not for finding the trace positives in particular, but I think for finding TB cases in general, yeah, I think there's a role for pooling expert
Yeah, it
specimens.
just seems like there's a whole line that you could go down there with,
Yeah.
handling of all of those samples, spinning them down.
Hmm.
But we'll move on. David Horn had a question, but it looks like it's been answered. Neela and Andrew had a similar question. Go ahead, Neela. Or Andrew. Or I can read it if they're not here. So their question was, curious if you think these data support a practice of sputum induction on all household contacts of a TB patient rather than TST or IGRA alone. So in specific settings or anywhere, since household contacts are high risk. So why don't we go
Yeah.
to
Yeah. So, I guess there are two questions. I'm
everybody
sorry.
who's a. Mhm. Go ahead.
Oh, no, sorry. Yeah, so I guess there are two questions there. Like, should household contacts be tested on for active disease, even if they aren't reporting symptoms? And then is sputum induction the way to do it? I do think that there are not our data, but others who have shown that there's like a pretty high prevalence of the prevalence of TB among household contacts at the time of initial contact investigation in a lot of populations is sort of comparable in magnitude to the cumulative incidence that you expect to see sort of over time after your contact investigation. So you want to make sure you're detecting those prevalent cases that are already in the household. And if we know that like roughly half of prevalent TB in general, this is not among household contacts in particular, but I think there's some household contact data to support that the numbers are similar, that if half of your household contacts with prevalent TB at the time of your contact investigation are going to be asymptomatic or have a negative symptom screen, then I think it does push you to do some sort of investigation for active TB, even among people who are asymptomatic, whether that's chest x-ray, if you have access to chest x-ray, or whether it needs to be induced sputum versus, we were surprised how successful we were at getting people to give us a sputum. These are adults, and children obviously would need a different approach, but in terms of adults, sort of coaching people through taking deep breaths, doing some exercise that's going to get them breathing heavily and then cough up whatever they can. We were able to get something that seemed with a sensitive molecular test to be sufficient to find TB.
Hmm. Indeed. Yeah, I appreciated your consideration of the fact that, if you have 1% of the people had tuberculosis, it's relatively rare if you look at the whole population. So the possibility that these would be false positives certainly has to be carefully considered as you're doing. I wonder, that really bumped up a lot when you looked at the venues. And I was wondering, were there what is a venue, and what, I mean, know general what it's used in this type of study, but were the venues, and did they cluster in a certain type of venue?
Yeah, so we conducted it was a small number. We conducted about 10 of these venue events. And the venues there was a mix of things, but these were generally kind of dense residential areas where we were doing the screening. And a venue was setting up a tent in some space that we thought people would be able to access easily. And one was outside a church, one was outside the local chairman's house, one was near a local market, or just along a busy, like in an open field along a busy road. Places like that. I mean, our Ugandan field staff chose the locations in consultation with sort of the local community health workers and political leaders. But yeah, it was just kind of an open, easily accessible site. We'd announce them ahead of time on sort of local radio and the word of mouth, and get people from just the sort of surrounding. I mean, this whole geographic area, our whole study area was just over 2 square kilometers. And then, we're talking about much smaller areas within that we were targeting with each of these events. So it was really kind of a neighborhood level thing that we were trying to get people to come out to.
Okay. So I don't see any other questions in the chat, but does anyone else have any questions that they want to just ask?
This is Andy Vernon. Can you hear me?
Yeah,
Yes.
Hi, Andy.
Hi. Very nice talk and very interesting work, Emily. That's great. I wondered how you think about this work focused on subclinical TB in relation to the questions about the role of active case finding and its relative importance overall in comparison to emphases on preventive therapy, for example. I remember that your former colleague Jacques Grosset used to reflect on this, and he used the analogy of the tub running over in the bathroom with the door closed, and asked, does it make more sense to mop up water underneath the door, or does it make more sense to turn off the faucet? And so your talk adds another aspect that leads to this of consideration of this discussion.
Yeah.
Thanks.
Yeah, I mean, I guess I am inclined to say that that combining the two is what makes the most sense. That you want to ideally rule out subclinical TB when there are guidelines that don't necessarily say you have to exclude, you don't have to do anything more than symptom screening before, providing preventive therapy in certain populations. But I guess I would say the optimal strategy, if you're going to try to deliver prevention on a large population scale, is to test for rule out active TB, and then give preventive therapy. But taking into account at least ruling out like high bacillary burden asymptomatic disease before you give preventive therapy. I mean, I think another question that remains to be answered is if some of these like low bacillary burden, like if some of these trace positives are active TB, but it's paucibacillary, would preventive therapy be enough to cure them? But I think combining an approach that it can at least exclude high bacillary burden subclinical disease, and then after excluding that, providing preventive therapy for the people who screen negative is probably the optimal approach. That stop the bathwater and mop it up at the same time.
Yeah, I guess you could answer. You could approach some of these with mouse studies, and it would be probably interesting to consider that, since the issue of the use of preventive therapy with only a symptom screen, as currently used and practiced in some areas of the world, raises that concern as we push to shorter and shorter regimens for preventive therapy.
Mm-hmm. And I think it's the question of probably bacillary burden there, and which which subclinical cases, the smear positives, you probably don't want to get preventive therapy to, but some of the paucibacillary cases, I think there are questions after the Cordis trial and others recently in terms of, whether the preventive therapy is the right approach for these sort of early active disease. But yeah, I agree. Thanks.
Great. Thank you. Thanks very much.
Peter had a couple questions. Peter, why don't you fire away?
Let me see if I can figure out how to unmute. Okay. Hi, Emily. Nice presentation. One quick question. I'm sorry if you already answered this. The trace positives, how are they treated?
Yeah, so in our first pass through the community, we deferred to the local clinicians on treatment decisions, and sort of Ugandan guidelines were to repeat the test in HIV negative individuals before treating them, but in practice, most of them got treated right away. Currently, because we have this new sort of prospective cohort study, we are in general encouraging people to enroll into that study, in which case we only refer for treatment if we find additional evidence of TB, and otherwise we're closely following them prospectively without treatment to see which ones actually develop additional evidence of TB.
Okay, so treated for drugs though?
When they're treated, yes, they're getting just the standard national guidelines regimen.
Okay, so my second question is, in other areas, and a project that I did with this kind of intent, sort of deep screening, door-to-door community-based screening. Since you found all those early cases, TB incidence might drop precipitously hopefully in the next few years. Are you going to examine the impact on, the preventive impact of your activities there?
Right. Yeah. I mean, over the short term, at least, like I said, we're making a second pass through the same community now. And so we'll be able to look at, and we're using sort of biometric identifiers to figure out how much we're testing the same people versus different people in the same area. And so we'll know how much TB, how much the same population is being rescreened and how much among those we were previously tested and others in the same area, the prevalence has dropped compared to 2 years earlier. We're also looking in the short term at impact on notification rates in the local health facilities.
Okay, that's my question. Yeah. Yeah. Thank you. Cool.
Yeah.
David Horn. David. David's still there.
I can answer the question asking about including children under 15.
Go ahead. Yeah.
Okay. We don't currently have plans to include children under 15 in these sort of sputum-based case-finding studies, and partly because we're interested in transmission and think that they play a relatively small role in transmission, and because sputum-based testing is just difficult in children. We have been doing contact investigation among child contacts of the cases we identify. In terms of TB preventive therapy, the current policy guidelines are just preventive therapy for HIV, people with HIV and children under 5 who are a known contact. And we, in the context of this study, we've been doing tuberculin skin testing of all household contacts and trying to get others referred for preventive therapy, but at this point, guidelines are just children under 5, although we have spoken with the National TB Program about some other upcoming studies, and there's interest in expanding preventive therapy, for example, as part of the sort of active case finding, rule out active TB, and then refer people who have latent but not active disease for preventive therapy. And the TB program has expressed interest in that, although the guidelines don't currently recommend it.
Wonderful. Well, Emily, thank you again so much for presenting. Really, really interesting and a lot to think about. Also, I'd like to thank Lady and Mandy for their work in organizing this. And everyone, please stay tuned, and we will be scheduling another one in the next couple months. And thank you all for your time today. Have a great weekend.
Great. Thanks so much. Bye, everyone.